soaring high and making difference, where we talk anything about nursing. So let your voice be heard right here. Moments with Professor X. Good afternoon, nurses. I am back. It's me again, Sander. How's everybody? Today is May 14, 2025, and it's 1:20 p.m. my time. So that makes it May 15 in the Philippines, Thursday, and that will be 4:20 a.m. So good morning, everybody in the Philippines. How's everybody there? How are you, angels in the sick room? Hold on, give me like few seconds. I need to share this stream to other Facebook pages and other platforms. Okay, hold on. Perfect. Yep. Anyway, how's everybody? My God, it's been a while. The last time I did stream was last week. And this is actually in response to a student who requested a specific topic for me to talk about. So big shout out to a student from Dubai, UAE, to my student Mendes Shah. So she requested this topic today. And was it Mendes Shah? Hold on. So this is her request. There. So this is for you, Mendes Shah. Just a heads up. Oh wait, where is that? There. So she said, "Sir, can you discuss about vasopressors?" Okay. So vasopressors are agents usually given to patient with a very low blood pressure, especially to patient having issues with their tissue perfusion, or technically we say patient in shock. So I took the liberty to add another topic, and that is shock, because I think it would be better and best that if I will discuss shock and then followed by different agents like your vasopressors, that time you'll be able to appreciate why are these agents or this specific drug or medicine given to patient, okay? And of course, apart from that, I will also incorporate common questions in your Nclex here. And by the way, speaking of Nclex, just a heads up that this session will benefit more those students who are planning to take the Nclex-Rn examination, not much to those who are planning to take the Nclex. So those who are planning to take the Nclex-Rn, not the Nclex-PN. Okay, so again, the Nclex-Rn are those students who will benefit more on this session. But if you are planning to take the Nclex-PN anytime soon and you just want to stay and learn something, then you are cordially invited. That's fine with me. But again, those who are planning to take the Nclex-Rn will benefit more on this session. So again, we will talk about shock and vasopressors. So it's a huge concept. It's a big one. So I decided to make this into two parts. So part one, we'll talk about shock. And part two, that will be tonight, my time, we will talk about agents, your vasopressors. Not only vasopressors, I will also include inotropes, chronotropes, inopressors. I know those words are maybe common, or you met them when you had your clinical exposure. So this session, I will just to reinforce this and somehow refresh you about those medications and conditions of your patient. Okay, what am I talking about? Anyway, so let me try to share my screen, and then let's go from there. And by the way, if you have any questions or concerns, please let me know. Oh, I have another shout out here. Hi, Sir John. Shout out from Canada. Kat Huwag po. Hi, how's everybody there? Oh, speaking of Canada, we're in Canada. I was in Vancouver. When was that? 2 weeks ago. Remember the one, what was that? Was it Lapu-Lapu Festival? I was there when it happened. That was 2 weeks ago. I stayed there for a couple of days before flying back in Vegas. How are you, Kath? I miss you. Correct me if I'm wrong, Kath. You're from Cagayan de Oro City, right? Please. I'm sorry if I was wrong, but I think I have a gut feeling that you're from Cagayan de Oro City. Oh, I'm here in London, Ontario. How far is that? How far is that from Vancouver? How far is that from Vancouver? Yes, from CDO. Michael Legaspi's best friend. Oh, I remember Michael. Is Michael still in CDO? Where is he working now? Okay, Vancouver is like 8 hours flight. Man, that's too far. I've never been to Ontario. What's good in there? I like Vancouver. I mean, I learned to love the place. I mean, the weather was good when we went there. Yes, Michael Steele at CUMC. Okay, big shout out to all nurses at Capital University Medical Center, and of course to my good friend, Dean of College of Nursing, Dr. Fidela Ansale, and of course to my good friend, the Director and CEO of Aim to Top Review Center, Gift Paguntalan. Hi, everybody. Anyway, let's move on. What is this? Toronto, Niagara Falls. Oh, okay. You know, I went to Niagara Falls. Oh, when was that? 2 or 3 years ago when I was still staying near the area. I don't know if you're familiar with Erie, Pennsylvania. So it's just like less than 3 hours drive from Erie. I used to go there, cross the area and go to Jollibee. Anyway, so let's move on. Let's talk about shock. Okay. Am I still online? Just making sure. Okay, let's talk about shock. Let me share my screen and let's go from there. Hello to my 17 subscribers. I know it's 4 o'clock in the Philippines, so please, to all my students back home in the Philippines, you can watch this video, download, replay as often as you want. No issues. I'm taking Nclex this July, sir. Good luck. Hopefully you will make it. Please let me know if you want some coaching. I can help you, give you some, handouts and something to read to prepare for your Nclex-Rn. Okay, let me share my screen. Okay, so let's talk about shock. Shock is a critical condition brought by altered tissue perfusion. So what do you mean by this? If shock is a critical condition, it's safe to say that shock is a form of a medical emergency. Okay? Oh, by the way, there's another comment here. Hi, sir, watching from Saudi Arabia. I remember your lectures in SLRC Jensen before last April 2013. During my review for the Philippine Nurses Licensure Exam. Hi! And speaking of SLRC, hello to Tita Emmy, the director of St. Louis Review Center, General Santa City. Yeah, I remember that. How's everybody there in Saudi Arabia? Oh, by the way, speaking of Saudi, last year I did a final coaching for the medical surgical nursing for those who, I guess, was it for the PNLE? Spearheaded by Red. I don't know if you know him. So hello to all my students in Saudi Arabia. Anyway, I need to proceed now. I barely have like 50 minutes to finish this before I will start my online session with nurses from Texas. So I need to finish this before 3 o'clock my time. So anyway, let's go back. Shock is a critical condition brought by an altered tissue perfusion. Again, it's a form of a medical emergency. Okay? So it is a condition wherein there is an altered tissue perfusion. What is perfusion? Perfusion refers to the delivery of gases, nutrients, blood, fluid to the different parts of the body. So when you say altered tissue perfusion, there is an issue, there is a problem with the delivery or passage of those substances I mentioned. Okay. Now, do not forget that in your NCLEX examination, that if you be asked about what's the goal, the treatment goal or goal in treating patient with shock, the answer is always to improve perfusion. Okay. Now, question: how are you going to improve perfusion? So to answer that, you have to treat the underlying cause. Remember, there are different types of shock. That is why the management differs. Okay? But there are common denominators or common drugs that can be given to your patient. So regardless of what you do, whether you give something, a medication, a fluid, or a specific medicine, they all boil down to improving tissue perfusion. Okay? So take note that there are 4 types of shock. So we have this, what we call hypovolemic shock, distributive shock, cardiogenic shock, obstructive shock. Maybe you're looking, what about septic shock, anaphylactic shock, and then there is also neurogenic shock. Where are those now? So take note, your distributive shock has 3 subtypes. Okay? Your distributive shock has 3 subtypes. We have this septic shock. We have anaphylactic shock. And last is your neurogenic shock. Okay, so please allow me to describe these types and give me reasons why this condition happens to your patient. Now let's begin with your hypovolemic. Hypovolemic shock is a type of shock related to a decrease in your fluid volume. Okay, so again, this is related to a decrease in your fluid volume. Now, how did it happen? What conditions that can lead to a decrease in the fluid volume? Number 1, if you throw up a lot. Okay, so a patient with severe vomiting, severe nausea and vomiting is at risk to have fluid volume deficit, at risk to end up having hypovolemic shock if it's excessive form. Not only that, okay, give me a condition that can have severe nausea and vomiting. Remember, to pregnant mothers on the first trimester, there is an issue called hyperemesis gravidarum. If it's so severe, okay, it can result to fluid volume deficit. What else? A patient with, if you do frequent and excessive gastric suctioning, okay, so gastric lavage, gastric suctioning, okay, will also increase the risk of fluid volume deficit, and if not treated, can progress to hypovolemic shock. So anything that goes, okay, that gets out from your GI. So it also follows that if anything that gets out from your intestinal area, just like your diarrhea. So severe diarrhea can cause decreased fluid volume because of fluid loss, and which will eventually lead to fluid volume deficit, and of course progresses to hypovolemic shock. Okay, that's number 2. Third reason that can cause hypovolemic shock is burn injury, skin loss. Okay, remember in your burn injury, because of exposure to extreme heat, it causes injury to your skin, injury to your blood vessels. So an injury in the blood vessel will result to increased permeability, leading to fluid shifting. Okay, so that will decrease the plasma volume, that will affect blood volume, resulting to hypovolemic shock. Okay, another is if there is bleeding. Bleeding may be related to trauma. Okay, maybe bleeding related to an underlying condition. For example, patient with bleeding peptic ulcer disease, or a patient with bleeding, patient with bleeding, ulcer, or bleeding ectopic pregnancy, or patient with bleeding spleen may be related to trauma. Speaking of spleen, don't forget this. If you had an issue about or encountered a question in your NCLEX about vehicular accident, don't forget that one common organ that will rupture during vehicular accident is your spleen. Okay? So if you have spleen injury, spleen issue, spleen problem, don't forget that a spleen problem, okay, can give you pain on the left upper quadrant, and that pain can cause radiating pain to your left shoulder. Okay, left lower quadrant pain that can cause radiating pain to your left shoulder. Sometimes in NCLEX, they don't use the term left shoulder, they may use left scapular area. Okay, so take note, spleen is on the left side. So this is my left side. If you're looking at me, this is my left side. Okay, because I'm facing the camera. I know. Okay, So that's it. So fluid volume deficit. So what happens in your decreased fluid volume? A decrease in the fluid volume will eventually lead to a decrease in your stroke volume. Okay, what is stroke volume? Okay, we'll discuss that in a bit. Okay, I need to define stroke volume, preload, afterload, what else? Cardiac output, mean arterial pressure. Okay, so just listen what the different types of shock and what happens to your patient. Okay, so a decrease in the blood volume or fluid volume will result to decreased stroke volume. A decrease in the stroke volume will result to decrease in the cardiac output. Okay, a decrease in the cardiac output, of course, will decrease the blood pressure of your patient. Of course, it means that there will be a decrease in the mean arterial pressure. Okay, what is the relevance or significance if there is a decrease in the MAP or MAP? A decrease in the MAP would mean decreased perfusion to your tissues, leading to, of course, organ failure. Okay, next, distributive shock. Okay, distributive shock, don't forget that distributive shock is a type of shock attributed or related to vasodilation. Okay, vasodilation. Why? Remember, sepsis happens if you left an infection untreated. Now, it's common there for your elderlies. Don't forget, the most common reason of origin of sepsis for elderlies will be your UTI or urinary tract infection. If left untreated, that sepsis, that infection can progress to septic shock. Okay? Now, how did the patient with septic shock end up having vasodilation? Remember, if there's sepsis, there is infection, it triggers immune response. And that immune response will cause release of cytokines. I don't know how you say it, cytokines or cytokines. And those substances can cause vasodilation. Okay? Anaphylactic shock happens if you expose the person to an allergen. So when you say allergy or allergen, it means to say that when you expose a person to a specific substance, that person reacts violently, where a normal person will not have the same reaction. So it's a form of hypersensitivity. And because of hypersensitivity reaction, it triggers chemical mediators. It triggers release of your histamine. Okay, so once histamine is released, it causes vasodilation as well. Okay, neurogenic shock happens if there is trauma or injury into your CNS. So you say CNS or central nervous system, so it has something to do with the brain and the spinal cord. This condition usually happens or occurs to patient with spinal cord injury. So what happens with your SCI is that there is a disconnection of the brain to your body, affecting the sympathetic control, the sympathetic response. Remember that the sympathetic response is your fight-flight response. This is a response that can cause vasoconstriction. So if you don't have that sympathetic tone control, you don't have vasoconstriction, so you end up having vasodilation. Correct? So technically, a patient with distributive shock, the main issue is vasodilation. So what happens here is that, I'll just put it on this side. Because of vasodilation, this will result to a decrease in your systemic vascular resistance. Remember, when the blood vessels dilate, the resistance decreases. So when the blood vessels dilate, it decreases your systemic vasoresistance. So a decrease in your systemic vasoresistance will result to a decrease, okay, in your blood pressure. Okay, and again, it leads to a decrease in your MAP. Okay, now remember, these are all distributive shocks. Okay, now question, how will you identify that type of distributive shock is septic, this one is anaphylactic, that is your neurogenic? You have to assess your patient. Okay, so if it is septic shock, of course, related to infection, expect that their lactic acid is high. Okay, so WBC is high, there's leukocytosis. Anaphylactic, of course, there's exposure to an allergen. Okay, neurogenic if the patient has spinal cord injury. And speaking of SCI, just a side note, okay, which is a common question in your Nclex patient with spinal cord injury, especially if the SCI is above T6 or thoracic 6, okay? If you have a spinal cord injury above thoracic 6, it increases the risk of a condition called autonomic dysreflexia or we call that as your autonomic hyperreflection, that is usually triggered by a distended urinary bladder. That's the most common reason. Okay. Other reasons can trigger, other factors can trigger autonomic dysreflection, just like your physical stimuli. But speaking of your distended bladder, don't forget that a patient with SCI above T6, there must be an indwelling catheter. Don't forget that in your NCLEX. Okay? Now, the third type of shock is your cardiogenic shock. So cardiogenic shock is a type of shock. When you say cardio, it has something to do with the heart, right? So cardiogenic shock is a type of shock due to a decrease in the patient's cardiac output. Now, what is cardiac output? We know that the cardiac output is a product of heart rate and stroke volume. Okay, that's the formula, right? Cardiac output is equivalent to heart rate times stroke volume. So why did the patient end up having a decrease in the cardiac output? A lot of factors, and we will discuss that. But nevertheless, if the patient has a decrease in the cardiac output, this will lead to a decrease in the blood pressure. Okay? And again, a decrease in the blood pressure will lead to a decrease in the mean arterial pressure. And last is your obstructive shock. Obstructive shock is a type of shock attributed to what? This is a type of shock related to a decrease in the preload, okay, or related to an increase in the afterload. That is why I said there are terms I need to discuss, define before we move on, okay? So please allow me to discuss this. Preload, afterload, stroke volume, cardiac output, mean arterial pressure. Okay, these are terms that you need to understand so that when we talk about vasopressors, you won't have a hard time comprehending the concept. Okay, so what do you mean when you say preload? Any idea? What about afterload? What about stroke volume? That is why please, before you watch part 2 of this, you need to finish watching this part 1. Stroke volume, what else? Cardiac output. And last is your mean arterial pressure. There, that's the heart. So preload, what is the preload? A preload is a term that describes the maximum stretch of the myocardial muscle, your ventricles. This is the maximum stretch, okay, of the ventricles. What's wrong with my spelling? Hey. Ventricles before contraction. Okay? Afterload refers to the resistance that the heart needs to overcome. That's the best description. Resistance that the heart needs to overcome in order to pump the blood. Hold on, there's a message for me. What is this? Okay. Preload and afterload. Again, preload is the maximum stretch of the ventricles before contraction. Some would say this is the volume, this is the end-diastolic volume before systole or before contraction. We say contraction, it refers to the systole. When you say relaxation, that is your diastole or diastole. Now, look at the heart for you to better understand preload and afterload. Okay? Now, this is your right atrium. Okay? This is your left atrium. This is the right ventricle. and this is the left ventricle, the superior vena cava, inferior vena cava. Okay, now, during diastole or diastole, it means to say I'm referring to the ventricle relaxation. So during diastole, the ventricles are relaxed. That's the time, okay, that the atria will contract, okay? So when the atria contract, it fills the ventricles with blood, okay? So it only happens when the ventricles are relaxed, okay? So if it's relaxed, it can fill that with blood. So as the blood fills the ventricles will stretch to accommodate the blood filling the area, okay? Until such time, okay, the ventricles reach its maximum stretchability, okay? So until such time that the ventricles reach its maximum stretch, okay, just before it contracts, you call that condition, you call that phase there as your preload, okay? So the preload is the maximum stretch of the ventricles before it contracts, before it will go into systole or systole phase. Okay? Now, when the blood is in the ventricular area, okay, remember, this is the right ventricle, this area is the left ventricle. In order for this blood to be pumped out, remember that the right ventricle pumps the blood to your lungs. The left ventricle pumps the blood to your systemic circulation. They should overcome the resistance in order to pump the blood out. Whatever is the pressure in the pulmonary area, the ventricle needs to overcome that pressure. Whatever is the pressure in the systemic area, the left ventricle should overcome it. So just for the sake of argument, if the energy or pressure in the pulmonary is 10, the right ventricle must use a pressure of greater than 10 to overcome that. If the pressure in the systemic is 80, the left ventricle needs to exert a pressure of more than 80 to overcome that. Failure to overcome the resistance means it cannot pump the blood out. So you call that resistance that the resistance that the heart needs to overcome to pump the blood out. You call that as your afterload. Okay? So it means to say that the afterload of your right ventricle is dependent to your pulmonary area. The afterload of the left ventricle is dependent to your systemic area. Okay, I hope that's clear. Now, what is the afterload of the pulmonary area that the right ventricle needs to overcome? About 20 millimeters mercury. And for your left ventricle, what is the resistance, the vascular resistance that it needs to overcome? About 80 millimeters mercury. If you can remember, that is the diastolic pressure. Remember, the average is 120 over 80 blood pressure. So 80 is your diastolic, that's your 80 millimeters mercury that the left ventricle needs to overcome. Having said that, if your patient is hypertensive, if the blood pressure is consistently above the normal average, it means to say that the left ventricle is overworked. It means to say it's overworked in order to pump the blood out, resulting to enlargement of the left ventricle, leading to left ventricular hypertrophy. That is why as a nurse, please do not forget to remind your patient to take their blood pressure medication religiously. Do you know that according to research, this is evidence-based practice? If your patient is religiously taking their antihypertensive medication, it prolongs their life for about 10 years. So this is a very simple nursing instruction, and it helps the patient. Okay, so please do not forget that. Educate your patient, okay, especially those who are hypertensive like me. Okay, so anyway, that is your preload and afterload. Hold on, if there are any questions, let me know. By the way, hello to Jaron Alvarez, Derry Espiritu, Antonio Amorado, Ovid Kasungkad, and Neil Ganashas, and 5 others watching with you. Okay, hello. So what about, what is the other one? Stroke volume. What is stroke volume? Stroke volume refers to the volume pumped every beat. It means to say that every time the heart contracts, it pumps the blood out. The amount of blood ejected or pumped by the heart every beat is your stroke volume. Okay? Now, what about cardiac output? Cardiac output is the volume, okay, pumped every minute. So every 60 seconds. So how will you get the cardiac output? The cardiac output, the formula is cardiac output is heart rate, multiply that by your stroke volume. Okay, remember, stroke volume is the volume pump every beat. So the cardiac output is the volume pump every minute. So it means to say that in 60 seconds, how many ml of blood is being pumped, ejected by the heart. So that's your cardiac output. Okay? Now take note that the stroke volume, average stroke volume is 70 ml. This is the average, 70 ml. What about mean arterial pressure? Mean arterial pressure, what is this? Mean arterial pressure is the average. This is the average pressure throughout a single cardiac cycle. Okay? This is an average pressure throughout a single cardiac cycle. And don't forget that the normal mean arterial pressure ranges from 70 to 100 millimeters mercury. Okay? But the average and needed pressure to maintain perfusion, okay? An average mean is 60. Okay? Mean is 60. So don't forget that the implication is that if you have a high or an elevated mean arterial pressure, it means to say that the arteries are stressed out. Okay? So if the arteries are stressed out, it increases the risk of myocardial infarction. Why? Because if the mean artery pressure is high, the arteries are stressed out, it means that the heart is overworked. Okay? Why? It increases too much workload of the heart because it needs to resist that pressure, that resistance. So an increase in the workload of the heart would lead to increased myocardial demand, oxygen demand. So it increases the risk of MI. What else? Because of increased pressure, it increases also the risk of stroke. It increases the risk of cardiac complication. A decrease in the MAP or mean arterial pressure will affect perfusion. That is why you need to have at least 60 MAP to make sure that the perfusion is adequate, okay, sustainable for you. Now, how do we ensure that the mean arterial pressure is within this area or within this range? That is why you have your vasopressors. That is why you have your different medications, just to make sure that the MAP is within its range. Okay? That is why if you're working in the critical care unit, we use MAP as one of the factors to try titrate the medicine. Okay? To titrate the agent. We will discuss that in your part 2. Okay? Now, going back to different type of strokes, again, I said the fourth issue, obstructive shock. Obstructive shock is related to a decrease in the preload or an increase in the afterload. Let me give you an example. Give me a reason why there is a decrease in the preload. So one good reason why you have a decrease in the preload is that for patient with cardiac tamponade or patient having tension pneumothorax. Okay, what is cardiac tamponade or stamponade? Cardiac tamponade refers to accumulation of fluid surrounding the pericardial air surrounding the heart. So come to think of it, if there is a fluid surrounding the heart, it restricts the normal movement of the heart. So it means to say that because of fluid accumulation surrounding the heart cannot stretch to its maximum stretchability, if that's the right word. Okay, if a fluid surrounds the heart cannot pump properly, so it cannot stretch. So if the heart cannot stretch, it cannot feel enough blood inside. So that decreases the preload. Okay? Another reason why you have a decreased preload is a condition called tension pneumothorax. By the way, your tension pneumothorax is a complication of penetrating chest trauma or penetrating chest injury. The danger with your tension pneumothorax is a condition called mediastinal shift. Now, if you are very keen, okay, let me draw that. Please bear with my drawing. Okay, this is the right lung, this is the left lung. Okay, your heart is more on the left side, correct? Two-thirds size of the heart is on the left side. So this is your heart and this is your right lung. Okay, lung has two major covering. Okay, and between those coverings there's a space called your pleural space. So let's say you have here your penetrating injury, chest trauma. So you were stabbed on the right side on your right lung. So there is an open injury. There is penetrating injury. So because of penetration, it exposed your right lung to the atmospheric environment, allowing air to get inside. Okay, so when atmospheric air enters the pleural space, okay, you call that condition as your pneumothorax. Pneumothorax. Pneumothorax refers to air in the pleural space. Now, why do we call it tension pneumothorax? We call it tension because as air accumulates in the pleural area, tension increases. Why? This hole here, the punctured area, acts like a flap or a valve. That when you inhale, the hole opens and it allows air to get inside. When you exhale, the open area closes, trapping the air on the right side. And the cycle repeats. When you inhale, the hole opens, allowing air to get inside. When you exhale, it closes. When you inhale, it opens again, allowing air to get inside. And when you exhale, it closes. So technically, it allows air to get inside, filling the pleural space. As air accumulates on the right side, tension increases. Tension builds up, making this right lung to become a positively pressured lung, whereas the other lung remains negative. If it's a positive pressured environment, it pushes the other side. Why will it push the other side? Why will it push the other side? To accommodate increasing pressure, to accommodate increasing tension. So come to think of it, if the right lung pushes the other side, okay, it will displace your heart. So once the heart is displaced, you call that condition as your mediastinal shift. Mediastinal shift. So if there's mediastinal shift, if it displaces the heart, it compresses the heart, it restricts the heart, it affects the preload. Okay, that is why don't be surprised that the common cause of death for patient with tension pneumothorax is shock secondary to mediastinal shift. And by the way, since I mentioned mediastinal shift, don't forget that one manifestation of your patient here is that the trachea ideally is on the center or midline. Because of mediastinal shift, it deviates to the other side. So don't forget, ideally the trachea is on the center, but if it deviates, it's a medical emergency. Deviated trachea would also mean airway obstruction. And don't forget in Nclex, if there is deviated trachea, where will it deviate? Towards affected side or unaffected side? Look at the picture. The bad side is the right side. The unaffected side is the left side. So if you have deviated trachea, the answer in your Nclex is deviated trachea deviates to your unaffected side. That's the question and that's the answer. By the way, what do we have here? Okay. So I hope that explains your decreased preload. What about increased afterload? Remember, afterload refers to the resistance that the heart needs to overcome, right? Now look at your right ventricle. Remember that the right ventricle pumps blood to the lungs. And this is a big vessel. This is your pulmonary trunk. And this pulmonary trunk will bifurcate into pulmonary arteries, right? So come to think of it, if you have a big clot inside, a massive clot, that clot obstructs the normal flow of blood. So if there is no blood that can pass through, then there is no blood that will get inside the left side of the heart because of obstruction. So as a result, if there is increased resistance because of a clot, that decreases the cardiac output. That decreases perfusion. So what's the cause of your obstructive shock due to increased afterload? One good example here is your pulmonary embolism. If there is clot in the pulmonary vessel. So a clot in the pulmonary vessel will result to shock. Okay, what type of shock is that? Obstructive shock. Okay, now I just want to emphasize something here. Paying attention to your cardiogenic shock. Remember, cardiogenic shock is due to a decrease in the cardiac output. Okay? Now, why do you have a decrease in the cardiac output? One good reason there is your... How do I do that? I'll just write it here. So cardiogenic shock is a type of shock due to a decrease in the cardiac output. Okay? So why do you have a decrease in the cardiac output? So this is related to a decrease in the contractility. So it means to say if the heart will not pump properly, will not contract adequately, it decreases cardiac output. Give me a condition wherein there is a decreased contractility of the heart. One good example here is history of myocardial infarction. Remember, in myocardial infarction, there is coronary occlusion. As a result, the heart will not die. The cardiac muscle, the cardiac tissue will die because of poor or inadequate blood supply. So come to think of it, if the muscles are dead, it will not function properly. It will not contract as effectively as it was before. As it was because of the sustained injury. So myocardial infarction can cause injury to your muscles. So when the muscles are injured, it will not pump well. Okay? Another example that can result to decreased contractility is patient with heart failure. Okay? What is HR? Patient with heart failure. Why did I write HR? Heart failure. Remember, heart failure is a condition that is characterized by failure of the heart to pump well, especially in the type of heart failure has a reduced ejection fraction, and it happens so sudden or acute. Your heart failure with reduced ejection fraction or may be attributed to patient with valvular defect or valvular problem. Okay, remember, if the valves are not closing well, there will be what we call reflux or regurgitation causing congestion in the heart. Okay, so heart failure. So due to decreased contractility. So you know that one management here is to give a medicine that will increase its contractility property. Okay? And that is what we call inotropes. Okay? Just like your digoxin, which is a positive inotropic agent. Okay? Another reason that can cause cardiogenic shock is if there is an increase in the heart rate or a decrease in the heart rate. Why? Remember that cardiogenic shock is a type of shock due to decreased cardiac output. And I mentioned that, what is the formula for your cardiac output again, if you can still remember? Where is that? Here. I said that cardiac output is the product of heart rate and stroke volume. It follows that if there is a decrease in the heart rate, okay, will result to decrease in the cardiac output, right? Because look at the formula. My question here is, why is it if there is an increase in the heart rate, it will also decrease the cardiac output? Because decreased heart rate bradycardia is justifiable. Because if there is increased heart rate, usually greater than 150 beats per minute, and take note, sustained tachycardia. If the heart rate is so fast, okay, if the heart rate is so fast, it decreases ventricular filling. It means to say, look at my hand. Here. It means to say if this is your heart and the heart beats fast than what is supposed to, it decreases the time, the adequate time for the blood to fill the heart because it beats so fast. So as a result, sustained tachycardia of more than 150 beats per minute will decrease time for the blood to fill the heart. That is why if less blood fills the ventricle as the heart contracts, less cardiac output. Okay, so take note. Decreased heart rate, bradycardia will decrease cardiac output. Sustained tachycardia of more than 150 beats per minute will also cause decreased cardiac output. Why? Because tachycardia of greater than 150, and if it is sustained, can result to decreased ventricular filling, leading to decreased cardiac output. Okay, so I hope those things are clear. So again, these are the different types of shock. So again, just to recap, 4 types of shock. We have the hypovolemic shock related to decreased fluid volume. Second type of shock is distributive shock. This is characterized by vasodilation, may be really attributed to sepsis, anaphylaxis, and neurogenic. The third type of shock is your cardiogenic shock. This is related to decreased cardiac output. And the fourth type of shock is your obstructive shock, may be related to decreased afterload, a decrease in the preload or an increase in the afterload. By the way, I forgot to mention this. Just a side note, which is very essential. Speaking of septic shock, sepsis, don't forget that one common issue with your sepsis is a condition called DIC, or disseminated intravascular coagulation. Okay, don't forget that the most common cause of DIC is septicemia. So in your DIC, it is both a clotting issue and a bleeding issue. Okay? Anyway, I hope you understood. Did I say it right? I hope you got it right. Okay, you understood the different types of shock. Okay, the hypovolemic, the distributive, the cardiogenic, and obstructive shock. Okay, so once you're done, you proceed to part 2, where we will talk about different types of agents. So in your part 2, we will talk about vasopressors. Okay. We will talk about, what was that again? Inotropes. We will talk about chronotropes. And then we will talk about inopressors. Okay? So this will be for part 2. Okay? There. Okay, let me see if you have any questions. Oh, by the way, thanks for watching. Who do we have here? Ralph U. Cabanlit, M. Jing Olivar, Hazel Salgado, Melissa Gilbert. Hey, Melissa, how are you? Anoj Gonzalez, Joe Edusma. Thanks a lot for watching. So anyway, I'll see you again tonight for the part 2. God bless everybody. And yeah. Thank you so much. God bless. I'll see you this afternoon. Or no, I'll see you tonight. Don't forget, watch this before you proceed to part 2. Bye, everybody.